It's a pleasure to be with you. The title of this session is Injury and Non-Infectious Disease, Part 2, Childhood Obesity. There are no disclosures for this presentation. Objectives include review the measurement of overweight and obesity, focusing on the body mass index, BMI. Review obesity-related health and emotional issues. Review the risk factors associated with childhood obesity. Review the 24 CDC Division of Nutrition, Physical Activity, and Obesity strategies to control obesity in the United States, and provide examples of programs using these strategies. The World Health Organization, WHO, defines overweight and obesity as abnormal or excessive fat accumulation that may impair health. Methods used to measure obesity and overweight include the body mass index, BMI, using calipers to measure skin fold thickness, underwater weighing, bioelectrical impedance, dual energy X-ray absorptiometry, DXA, and isotope dilution. Most of these methods are expensive, require highly trained personnel, and are often difficult to standardize across observers or machines, making comparison studies difficult and unreliable. The BMI, though not as accurate as more expensive measures, is the most common measure of overweight and obesity used globally. The CDC states that BMI is an inexpensive and easy screening method for underweight, healthy weight, overweight, and obesity. BMI does not measure body fat directly, but appears to be as strongly correlated with various metabolic and disease outcomes as more direct measures of body fatness. BMI is calculated by dividing an individual's weight in kilograms by the square of their height in meters, or weight in pounds times 703 divided by the square of height in inches. BMI provides a useful measure of overweight and obesity for both sexes and all ages of adults. An adult BMI below 18.5 would be considered underweight, 18.5 to 24.9 healthy, 25 to 29.9 overweight, and 30 and above obese. WHO Child Growth Standards, launched in April 2006, includes BMI charts for infants and young children up to age 5, along with growth reference data for children 5 to 9 years old, and is a reconstruction of the original 1977 National Center for Health Statistics NCHS dataset, supplemented with additional data from the WHO. The same BMI formulas are used to calculate the BMI for children and adults, but the criteria used to interpret the values for children and adolescents differs from that for adults. For children, BMI age and sex-specific charts have been developed that provide percentile curves reflecting body fat composition changes that occur as a child transitions from birth through adolescence. In the United States, the CDC recommends using the WHO growth standards charts to monitor growth for infants and children from birth to 2 years of age, and the CDC charts for children aged 2 years and older. Using these growth charts, overweight is defined as a BMI that falls between the 85th and 95th percentiles for children of the same age and sex. Obesity is defined as a BMI at or above the 95th percentile. A child with a BMI less than the 5th percentile would be underweight. For example, as illustrated on the CDC BMI chart for children and adolescents from 2 to 20 years of age, a 10-year-old boy with a BMI of 23 would be considered obese, since his measurement would be beyond the 95th percentile. But a 15-year-old boy with a BMI of 23 would be within the healthy range, falling between the 75th and 85th percentiles. Childhood obesity has been identified as a global health concern since the 1960s. Obesity is associated with type 2 diabetes, high blood pressure and cholesterol, heart disease, stroke, gallbladder disease, pancreatitis, certain cancers, for example, breast, colon, and endometrial, osteoarthritis, sleep apnea, asthma, fatty liver disease, chronic lower back pain, kidney damage, and depression, with many of these conditions manifesting later in life. Pediatricians are now treating type 2 diabetes, hypertension, elevated cholesterol, and hyperlipidemia in obese children. A child with these conditions has a significant risk for heart and circulatory problems as they enter adulthood. Childhood obesity also has a negative impact on social relationships and sense of well-being, supported by research showing that obese children have a lower social status in school and are more likely to be the targets of bullying and teasing, often resulting in depression and low self-esteem. Children and adolescents who are obese have a 70 to 80% chance of becoming overweight or obese adults. Studies by Serdula et al. Demonstrated that obese children not only tend to maintain, but even increase their body mass index BMI scores into adulthood. This slide lists major childhood obesity risk factors, including country of residence, age group, gender, race and ethnicity, reduced physical activity, low socioeconomic status, food-related behaviors, parental obesity, and school food policies. Let's consider country of origin. In 2010, the International Association for the Study of Obesity, IASO, estimated that over 200 million children, 5 to 17 years old, were obese or overweight globally, ranging from 4.5 to 5.9% in China to 35% in the United States, second only to Greece at 37 to 45%. For age grouping and gender, using National Health and Nutrition Examination Survey NHANES data for children and adolescents in the United States from 2017 to 2018, the obesity prevalence was 13.5% among 2 to 5-year-olds, 20.3% among 6 to 11-year-olds, and 21.2% among 12 to 19-year-olds, with obesity rates higher among boys than girls in all age groups. Obesity prevalence varies with race and ethnicity. Obesity prevalence was 26.2% among Hispanic children, 24.8% among non-Hispanic Black children, 16.6% among non-Hispanic white children, and 9% among non-Hispanic Asian children. Native American children have the highest obesity rates, ranging from 20 to 44%, dependent on tribe and age grouping measured. Non-Hispanic Black girls have the highest childhood gender obesity rates across all races at 29.1%, and non-Hispanic Asian girls had the lowest rates across all races at 5.1%. Other risk factors for childhood obesity include reduced physical activity, associated with increased time spent watching television, playing video games, and using a computer. In the United States, Lower socioeconomic status is also a risk factor for childhood obesity. Lower socioeconomic status is strongly related to poorer nutrition, often caused by fewer healthy choices in grocery stores located in low income minority neighborhoods, increased consumption of fast foods, often due to cost, convenience, and availability, and the higher cost of more nutritious, lower calorie foods. Hemmingson suggests that the stressors associated with low socioeconomic status can further motivate poor nutritional choices, leading to obesity. Longitudinal studies have found a strong association between obesity and sugar sweetened beverage consumption. Some studies have shown that children buying lunch at school, eating supper while watching television, eating without family member supervision, consuming less calories at breakfast or more at dinner, and missing breakfast are associated with child obesity. If a parent is obese, their children have double the chance of also being obese. Children mimic the eating habits of their parents. There may also be a familial link, since children of parents who were obese as kids tend to have high BMIs. Schools can have a positive or negative influence on childhood obesity, dependent on the types of foods and beverages provided or made available to children. For example, the presence of soda vending machines in schools often enables children to make poor nutritional choices. This information underlines the importance of effectively preventing and controlling childhood obesity. The Nutrition, Physical Activity, and Obesity Program, operating under a cooperative agreement between the CDC's Division of Nutrition, Physical Activity, and Obesity and 23 state health departments, define prevention policies and practices to prevent and control childhood obesity. NPAO's goal is to prevent and control obesity and other chronic diseases through encouraging healthful eating habits and physical activity. Participating state programs develop strategies to leverage state resources and coordinate statewide efforts through multiple partners to increase physical activity, increase the consumption of fruits and vegetables, decrease the consumption of sugar sweetened beverages, increase breastfeeding, initiation, duration, and exclusivity, reduce the consumption of high energy dense foods, and decrease screen time. States are guided by 24 strategies outlined in the CDC's recommended community strategies and measurements to prevent obesity in the United States implementation and measurement guide. The authors state, this guide seeks to reverse the U.S. obesity epidemic by transforming communities into places where healthy lifestyle choices are easily incorporated into everyday life. To reverse the obesity epidemic, we must change our physical and food environments to provide more opportunities for people to eat healthy foods and to be physically active on a daily basis. This table lists the 24 CDC strategies to help address obesity in the United States. We will briefly review one example program for each of these strategies. 1. Increase availability of healthier food and beverage choices in public service venues. In St. Paul, Minnesota, the 5-a-day Power Plus program increased the variety of fruits and vegetables offered in schools by providing an additional fruit item on days baked desserts were being served. This program actively promoted fruits and vegetables to students and enhanced their attractiveness. Evaluation of the program found that fruit and vegetable consumption increased significantly among intervention children versus the control group. 2. Improve availability of affordable, healthier food and beverage choices in public service venues. The New York City Department of Health operates the Health Bucks program to make fruits and vegetables more affordable to residents who receive food stamps. For every $5 worth of food stamps spent at farmers markets, individuals receive a $2 Health Bucks coupon that can be redeemed year-round at more than 30 farmers markets citywide. In 2007, the City Health Department reported that New Yorkers used more than 40% of the 9,000 health bucks distributed in 2006. 3. Improve geographic availability of supermarkets in underserved areas. The Philadelphia Food Marketing Task Force released 10 recommendations to increase the number of supermarkets in Philadelphia's underserved communities. A new funding initiative was created using public funds to incentivize this initiative. To date, the initiative has committed $67 million in funding for 69 supermarket projects in 27 Pennsylvania counties, creating or preserving 3,900 jobs. 4. Provide incentives to food retailers to locate in and or offer healthier food and beverage choices in underserved areas. The city of Richmond, California, attracted a national discount grocery enterprise to build a store near an urban housing project by offering an attractive incentive package that included a reduced building site price, a federal urban development action grant of $3.5 million, a tax incentive due to a favorable zoning designation, negotiation assistance with regulatory agencies, improvements to sidewalks, streetscape, traffic signals, and concessions in the store area. 5. Improve availability of mechanisms for purchasing foods from farms. In 2005, Jefferson Elementary School in Riverside, California, launched a farm-to-school salad bar program that provides elementary school students access to a daily salad bar stocked with a variety of locally grown produce as an alternative to the standard hot lunch. Two small, locally owned family farms within 30 miles of the school sell their produce at an affordable price and make weekly deliveries to the school. Since implementing the Farm to School Salad Bar program, the Riverside School District has expanded the program to 4 additional elementary schools. 6. Provide incentives for the production, distribution, and procurement of foods from local farms. The Hartford Food System in Connecticut is a nonprofit organization working to create an equitable and sustainable food system that addresses the underlying causes of hunger and poor nutrition facing low-income and elderly residents. In addition to developing innovative projects and initiatives that tackle food cost, access, and nutrition, the organization actively engages in food policy initiatives aimed at increasing production, distribution, and procurement of foods from local farms. 7. Restrict availability of less healthy foods and beverages in public service venues. The city of Baldwin Park, California, established nutrition standards for all snack foods and beverages sold in over 30 after-school programs, including snack offerings in vending machines. The after-school nutrition standards primarily focus on eliminating less healthy snacks and beverages that exceed recommended fat, calorie, and sugar intake for school-aged children. 8. institute smaller portion size options in public service venues. The Texas Department of Health Services developed the Tex Plate program to assist Texas restaurants in serving healthier portion sizes to consumers. Participating restaurants receive specialized 9-inch plates that indicate proper portion sizes of key food groups such as vegetables, protein, fruits, and whole grains. The program is designed to encourage participating restaurants to increase the vegetable and decrease the entree and starch portions of the meal. 9. Limit advertisements of less healthy foods and beverages. The Mercedes Independent School District in Mercedes, Texas, adopted a comprehensive student nutrition wellness plan in 2005 that includes a marketing component. The policy states that schools will promote healthy food choices and will not allow advertising that promotes less nutritious options. The plan also defines and prohibits possession of foods of minimal nutritional value at school. 10. Discourage consumption of sugar-sweetened beverages. In 2002, the Los Angeles Unified School District adopted a motion to promote health, which banned soft drink sales on school campuses, allowing only approved beverages to be sold in vending machines, cafeterias, and student stores. It also monitored compliance, disseminated information on healthy beverage sale options, and developed a new revenue model to make up for an anticipated net loss of monies related to the ban on soft drinks. 11. Increase support for breastfeeding. In 1998, California passed the Breastfeeding at Work law, which requires all employers to ensure that employees are provided with adequate facilities for breastfeeding or expressing milk. In 2002, the state passed the Lactation Accommodation Law that expanded prior workplace provisions to require adequate break time and space for breastfeeding or milk expression, with a violation penalty of $100. 12. Require physical education in schools. In 2006, West Virginia enacted Senate Bill 785 that directs the Department of Education to establish a requirement that every student enrolled in a public school participate in physical education (PE) classes during the school year. The bill also specified participation times by grade level. For example, elementary school students are required to participate in at least 30 minutes 3 days a week. Middle school students, at least one full period of PE each school day for a semester. And high school students must complete at least one full course credit of PE prior to graduation. 13. Increase the amount of physical activity in physical education programs in schools. Owensboro, Kentucky, overhauled its school-based physical education curriculum after a study found that 60% of the area population was obese or overweight. A partnership was formed between the city's hospitals and schools, and $750,000 was donated to equip 11 school-based fitness centers with treadmills, stationary bikes, rowing machines, and weightlifting stations. Teachers were trained using new PE techniques, which stress the importance of keeping students physically active for at least 30 to 60-minute increments during class time. 14. Increase opportunities for extracurricular physical activity. Michelle Obama's Let's Move campaign was the First Lady's initiative to reduce the rates of childhood obesity. It focused on giving parents the tools to encourage healthy eating, promoted physical activity for young people, and worked to ensure all people have access to healthy, affordable food. This is an example of prominent public figures who have focused on the childhood obesity epidemic. 15. Reduce screen time in public service venues. In 2006, the New York City Department of Health and the Mental Hygiene Board of Health amended the New York City Health Code, which regulates group daycare. The amended article prohibits non-educational television, video, and visual recordings for children younger than 2 years of age and limits the educational use of television, video, and visual recordings to 60 minutes per day for children 2 years or older. 16. Improve access to outdoor recreational facilities. Kaboom is a national nonprofit organization that empowers local communities to build playgrounds. The Kaboom program helps communities identify resources, volunteers, and planning needed to provide playgrounds within walking distance of every child in a community. The Kaboom website provides information and resources for community residents to apply for a Kaboom-led playground project or access detailed plans to build their own playground. 17. Enhance infrastructure supporting bicycling. Boulder, Colorado committed 15% of its annual transportation budget, $3.1 million, toward bicycle enhancement and maintenance activities. More than 95% of Boulder's major streets have bicycle lanes and facilities, and all local and regional buses are equipped with bike racks. In addition, Boulder has created an online bike routing system that provides cyclists with direct and safe bike routes to travel within city limits. In May 2005, Boulder was awarded the gold status as a bicycle-friendly community by the League of American Bicyclists. 18. Enhance infrastructure supporting walking. In 2002, Oakland, California adopted a pedestrian master plan, which identified streets and intersections needing pedestrian safety work. The city estimated pedestrian volumes throughout the city based on land use, population, and other network characteristics, and used these estimates in conjunction with crash data, traffic data, and community input to identify and prioritize areas. 19. Support locating schools within easy walking distance of residential areas. In 2005, the city of Milwaukee initiated a neighborhood schools initiative. The city built 6 new schools and spent millions of dollars revamping and expanding dilapidated schools centrally located in neighborhoods with the goal of reducing the number of students being bused and at the same time encouraging students to walk or bike to school. 20. Improve access to public transportation. Local business owners and residents of the South Park neighborhood of Tucson, Arizona, received funding from the local government and the Federal Transit Administration, FTA, to implement a series of improvements to the existing public transit system. Funds were used to install 6 new artistic bus shelters, new traffic signals, and additional sidewalk and curb access ramps for public transit users, bicyclers, and pedestrians. As a result of the efforts to revitalize its public transit infrastructure, South Park has experienced renewed pride in its community and helped to rebuild its local economy. 21. Zone for mixed-use development. The official growth management policy for Eugene, Oregon, focuses on developing multiple urban mixed-use centers that contain multiple transportation and transit options, shopping, consumer services, and basic amenities, including food access. By combining mixed-use centers with improved transit options, the plan aims to reduce dependence on automobile travel, encourage walking, and reduce the need for costly street improvements. 22. Enhance personal safety in areas where persons are or could be physically active. Detroit, Michigan has one of the highest home foreclosure rates in the country, resulting in a dramatic increase in the number of abandoned buildings and boarded up homes, which attract vandals and petty crime. In response, Urban Farming, an international nonprofit organization, collaborated with the local county government to transform 20 abandoned properties into active fruit and vegetable garden plots that feed the homeless and improve the aesthetic appeal of the city's neighborhoods. The local county government donates water to maintain the city gardens. Since establishing the gardens, residents report less vandalism in their community. 23. Enhance traffic safety in areas where persons are or could be physically active. In the mid 1990s, the city of West Palm Beach, Florida, adopted a downtown traffic calming policy to improve street safety for non motorized users. The city's main streets were retrofitted with important pedestrian safety measures, including raised intersections, two-way streets, narrower roadways, roundabouts, wide sidewalks, tree-lined streets, and shortened pedestrian crossings. As a result of these efforts, pedestrians feel that city streets are safer, property values more than doubled in the downtown area, and commercial retail space increased occupancy to 80%. 24. Participate in community coalitions or partnerships to address obesity. PEDNet in Columbia, Missouri is a community coalition that includes 5,000 individuals and 75 businesses, government agencies, and nonprofit organizations. The goal of the coalition is to develop and restore a network of nature trails and urban pedways connecting residential subdivisions, work sites, shopping districts, parks, schools, and recreation centers. There have been some successes in the battle against obesity in the United States. In 2014, the CDC noted declines in obesity among low-income preschoolers in 19 of 43 states and territories, with 20 states and Puerto Rico maintaining their obesity rate and obesity increasing in 3 states. In 2019, Anderson et al. Reported that the prevalence of childhood obesity in the United States increased from 5% in 1978 to 18.5% in 2016. Though there is evidence that the annual prevalence slowed from 0.4% to 0.7% per year between 1978 and 2004 to 0.1% per year between 2004 and 2016. Rates increased steadily through approximately 10 years of age and then leveled off. Generally, the prevalence rate of increase from kindergarten to third grade declined. Black and Hispanic children entering kindergarten were more likely to be obese versus other racial or ethnic groups. Though the public health tools we've discussed seem to be working, we still have a long way to go to control obesity in the United States. In summary, BMI is an inexpensive and easy screening method for underweight, healthy weight, overweight, and obesity. Pediatricians now are treating type 2 diabetes, hypertension, elevated cholesterol, and hyperlipidemia in obese children. Children and adolescents who are obese have a 70 to 80% chance of becoming overweight or obese adults. The 24 CDC's Division of Nutrition, Physical Activity, and Obesity Strategies is a good guide to help communities address obesity in the United States. The United States still has a long way to go to control obesity.